work 10 years ago. And I started Overdose Lifeline in 2013 because I lost my middle child, Aaron, to a preventable cause of death. And I was doing work at the Indiana Criminal Justice Institute to prevent causes of death from other unintentional causes like motor vehicle crashes. And I was completely unaware that Aaron's death could be prevented. Despite my 25 years of recovery, I didn't understand opioid use disorder. I didn't understand opioids. I didn't understand the real possibility that Aaron could return to use after treatment and lose his life. We didn't talk about substance use disorder as loudly as we are now. And honestly, the shame and stigma around this disease is very real. And as a mother, and as someone in recovery, and as an employee, I didn't want to go tell anyone and ask for help, comfort, or support. So I began to see the ways I could use my pain, as I heard someone say, to dismantle despair. And that's all I ever really wanted to do after losing Aaron, was to help others not feel alone the way that I did. And so I do this in honor of Aaron, but also in the honor of all the countless other parents who I stand alongside. So we started with Aaron's Law, which will be 10 years old next year. And that was to allow full access to the overdose reversal drug, some people call Narcan, but its generic name is naloxone. And we began to break barriers and distribute naloxone, and people started to reach out to me and say, thank you, I was able to save my child because of Aaron's Law. But it honestly wasn't an easy road in 2015, and it took a while for us to establish ourselves as a credible resource. Shame and stigma still existed. It was real within the law enforcement community then. It was real in government, and families were still afraid to ask for help. I also was a female, and so I was often told, you are probably just a mom with a sad story, as opposed to somebody who could actually do some credible work. So it took us a while, but we kept chipping away. And we did our best to fill gaps. Like we've been doing youth prevention education in the schools since 2015, and distributing access to distributing naloxone when we could, because there wasn't really funding in that way. But then in 2020, as Mr. Hunsinger mentioned, we partnered with the drug czar, his office, and the Division of Mental Health and Addiction to create more access to naloxone, because we were having a pandemic and the local health departments were challenged by that pandemic. And I never say no, for those of you that know me, and so we started doing this work, and I think we have a model in Indiana that other states should really consider adopting. So as Doug mentioned, and most of you know, the CDC reported recently that overdose deaths are down, and we have decreased overdose deaths by 19%, which is larger than the national average, and something to really be proud of. Also, I don't do this by myself, of course. We have this beautiful network of 200 distributors across the state. In almost every county, we have, the Department of Corrections helping us. And we've done really groundbreaking things, the way Doug mentioned, such as the vending machines in jail release lobbies, and the nalox boxes that are accessible to individuals 24 hours a day, 7 days a week. Just this morning, I received an email from a staff member at Ascension Health who told me, and I quote, "At the Washington Pavilion office on East Washington Street, a car raced into our parking lot with an unresponsive person in the car who had overdosed. Someone went to the nalox box and got out a kit that's outside their building and saved their life." So that's the stories that I get to hear and the true impact that we're having. And as Doug mentioned, we distributed the millionth dose on November the 4th. But access to naloxone is not the only thing we do in this remarkable public-private partnership. We believe in harm reduction and upstream prevention, and we believe that addressing this disease in the family is the best way for us to really reduce substance use disorder we are changing the intergenerational trauma for these kids. They are learning that they did not cause this disease and that they don't have to follow in the same path. And the program is actually evidence-based to reduce substance use amongst youth and juvenile justice involvement. Also through opioid settlement dollars and the support from the state, Overdose Lifeline runs one of the only recovery supportive housing for women who are pregnant and or parenting young children, a very challenging population, but very necessary to serve. And again, we believe through this model, we're changing the whole family's life. We're reducing the involvement of the Department of Child Services, and we're giving these children and their mothers a different opportunity for recovery. And then lastly, through funding from DMHA, we train peers who have a family experience in an evidence-based program called CRAFT. And this funding is free to these facilitators so that families affected by this disease can find their own community, because we know community is a key to recovery. And the family is often forgotten in the treatment of this disease, and so crucially important. So it's a bittersweet privilege to be here today, and in my wildest dreams I could never have pictured the journey to unfold this way. Some of you know me when Aaron lost his life, and so it's a small consolation for that loss, but I'm a better person, and I'm changed by the stories like the one I heard today from Ascension Health, and I'm grateful that I get to have an impact in other people's lives and make a difference for Indiana, so thank you for having me.
Thank you, Justin. And I just want to point out what Justin would not share and did not share, that her impact extends far beyond Indiana. In recent years, she's become a sought-after speaker on the national stage. In addition to all the work that she does locally, shedding light on the complexities of the drug epidemic and sharing strategies for prevention and intervention. And this year has been quite notable for Justin. She started off the year as a guest at the State of the Union. She has earned recognition as USA Today's Indiana Woman of the Year, and most recently being named to the exclusive Forbes 50 over 50 list. So sorry for putting an age there. But,
So I'm only 51.
just barely made it, right? And so for all of this, I mean, Justin embodies the collaborative spirit that
demonstrations have agreed upon metrics and outcome measurements that states must follow and document on a quarterly and ongoing basis to our partners at the Centers for Medicare and Medicaid Services, or CMS. In 2018, CMS issued guidance to states specifically offering the availability of these substance use disorder focus waivers. Indiana was one of the first states to take advantage of this opportunity and subsequently added a separate waiver demonstration for the treatment of serious mental illness. Currently, more than 30 states have an approved 1115 waiver for substance use disorder. Our initial demonstration period in Indiana ended December 31st, 2020, at which time the state subsequently was granted a subsequent demonstration. We are currently in this demonstration period, which runs from January 1st, 2021 through December 31st, 2025. As I mentioned, we are now in the process of applying for a 5-year renewal of this waiver, along with the renewal of our SMI waiver. One requirement of our demonstration application for renewal is an independent evaluation. Indiana contracted with Burns & Associates, a division of Health Management Associates, or HMA, to serve as our independent evaluator. Claims and encounters, member enrollment, and provider enrollment data were the primary sources for evaluating 55 outcome measurements. The evaluation team collected feedback from a variety of stakeholders to gain perceptions about the implementation of the SUD demonstration, as well as perspectives related to SUD service delivery for our Medicaid members. Data sources included one-on-one interviews with providers and provider associations, feedback via an online survey, and feedback from Medicaid beneficiaries and those with lived experience receiving SUD treatment, as well as interviews with our managed care entity partners, both individually and as a group. In this current demonstration, Indiana aligned its goals for the demonstration components with the milestones outlined and recommended by the Centers for Medicare and Medicaid Services. These are as follows. Reductions in overdose deaths, particularly those due to opioids. Increased rates of identification, initiation, and engagement in treatment. Increased adherence to and retention in treatment. Reduced utilization of the emergency department in inpatient settings where the utilization is preventable. Fewer readmissions to the same or higher level of care where the readmission is preventable. And improved access to care for physical health conditions among beneficiaries. In order to achieve those aims, Indiana has undertaken a number of demonstration activities as outlined on this slide. Many states seek the 1115 waiver authority in order to first address a longstanding challenge in providing Medicaid-covered behavioral health treatment, which is the IMD exclusion. This is a federal prohibition on federal match dollars for Medicaid reimbursement for individuals ages 19 to 64 who seek treatment in an institution for mental disease, which is defined as a psychiatric facility of 16 or more beds, primarily engaged in diagnosis, treatment, or care of persons with mental disease. This is a longstanding challenge that state Medicaid agencies grapple with. In addition to that, addressing that particular exclusion issue, you can see that Continued expansion of provider supply is unsurprisingly an area of focus that we will need to continue to view forwardly. Specific areas of focus were in the northern region of the state. Again, as I mentioned, the evaluation really focused on geographic areas, and while the supply rate grew significantly in the central and southern areas of the state, the northern area of the state grew at a slower rate. Administrative simplicity continues to be an important area where providers need support. Streamlined authorization request forms, specific provider manuals for Medicaid that are focused on SUD, additional trainings, and conducting a root cause analysis regarding the lack of awareness and low uptake for early intervention services among providers were recommended in the evaluation. And finally, we did not see as high of care management oversight metric growth as we had anticipated. A need exists to continue strengthening our work with our managed care entity partners, specifically in the HIP program, local units, receiving 606 submissions of 648. Using a platform that we built in-house, we spent countless hours individually contacting clerk treasurers and auditors in an attempt to collect those reports. At that time, 81% of the reporting subdivisions had not taken any action with their abatement funds, and 87% had not acted on their unrestricted funds. This year, in an effort to maximize efficiency and achieve a larger number of submissions, we partnered with a team of consultants and engineers at Aegis, formerly known as Beam Longest Neff, to develop a robust reporting platform, provide technical assistance, and collect reports from all 648 local units of government. Each community's designated respondent, typically the clerk treasurer or auditor unless otherwise noted, received a link on August 1st to access the reporting platform and had about a month and a half to complete that report. Total amounts received to date were auto-populated for communities so that they didn't have to go back and look to determine and there was no issues. And the reporting entity that was then responsible for identifying the total amount of funds expended during that reporting period, which was August 1st, 2023 through June 30th, 2024. The purpose of each expenditure and the qualifying strategy were Exhibit E of the National Opioid Settlement Agreements. Of the 648 local units of government, we successfully gathered 644 reports. In your folders, you'll find the abridged version of this year's comprehensive report, which does not include the 13 attachments that total more than 70 pages. On page 3, we break down whether funds were spent, with 80% or 501 communities reporting zero expenditures using restricted funds, and 82% or 526 communities reporting zero expenditures using unrestricted funds. Please note that the numbers represented in that restricted chart do not add up to 644, and that's because a number of municipalities reported a transfer of their restricted funds totaling under $5,000 to the county to comply with state statute, which we did not count as an expenditure. While not required, we also asked locals to identify whether they had established a local committee to oversee the allocation of their local settlement funds, of which 16% or 103 communities had said they created a committee. Upon analyzing these communities with a committee, we found that many of these were the same that reported at least one expenditure of either the restricted or unrestricted funds. In addition to local reporting, we also provided a breakdown of state spending. On page 5, you'll find an overview of how state restricted funds have been obligated since the State Budget Committee approved FSSA's first spending plan in December 22. An overwhelming majority of funds, nearly $35.5 million to be exact, have gone toward treatment and recovery, and that's a reminder that those are state funds. Included as an attachment is also a breakdown of how Indiana has spent its unrestricted funds. Those are appropriated by the legislature for oversight and administration of DMHA and other related addiction programming. In August, we presented So yes, in state statute, if the city or town's annual distribution is under that 5,000, then their annual distribution must be distributed to the county, and that is done. And I don't know Corey if you have anything to add on that, but that's done by the state before it gets to the county. And so we did have in August 2023 an issue where some of those cities and towns did receive their distribution of under 5,000, and so they were asked to reconcile that by sending it to the county, which goes back to the report why some of those communities were not listed as expenditures.
Is there any prohibition to units of government forming interlocal agreements to actually pool even greater resources than the $5,000 and
Yep.
below? Okay.
So that's allowed in statute as well. And we have actually had a number of communities reach out who, even if they're receiving a little over 5,000, it's still just not a large sum of money to have maximum effort or impact. And so we've specifically worked with AIM. Beck McWay has been super helpful in starting those conversations with communities to ensure that if they do want to pursue a local agreement, an interlocal agreement, that they can use it.
And then one final question along the same line. For your pie chart where we have community committees and you have 16% or 100, are those, again, larger communities, the counties, or larger municipalities that are really in that slice of the pie?
It's a good balance. So if you remember, I think it was last year, we had Clinton County and the city of Frankfurt come and present. They are one of those communities who have created a committee, and it consists of county commissioners, the local, their Healthy Communities Foundation, the mayor, just to ensure that they're getting all of the voices at the table. And so obviously we've seen that correlation between the communities who have created a committee and those who have not, which is why that's the first recommendation that we make. And then also list who should be a part of that committee if that is something that you pursue.
And anecdotally speaking, I will say the communities in which have either presented with us or before us or we're familiar with and are communities that have been working on this for a long time, they're the ones that are spending their dollars regardless of the amount that they're receiving. So that cooperation piece, I think, is what is driving communities spending their funds or utilizing their funds.
Like any new program, part of it is just getting started, right? And then you kind of evolve that over time.
Yeah, and I will say, I think it's okay. Something that we've acknowledged is it's okay that communities have not spent their funds yet. I don't want people to look at that 82 or whatever that percentage is and think, well, why are they just sitting on these? Because some communities have made the decision to either invest those dollars or sit on it for a little bit until they get a little bit larger sum of money just over those 18 years. And so do want to emphasize that that is not a bad thing necessarily. However, we know there are a lot of communities who just still do not know where to start, and so we want to provide that guidance to them.
And
Oh, I just want to say thank you. It's great to see this all at work on the ground after the settlements, and it makes me feel really good to hear all this. I had the same question as you did as far as the committees. 103 strikes me as a good number, and I'll tell you why. Is when you compile these 600 something odd local subdivisions, you're talking about a ton of small little towns in Indiana, and not cities and counties. And this probably indicates that there's a lot of counties and a lot of large cities that have put these committees together. And I remember Clinton County coming in and being impressed by the coordination within that county and what they were doing. And I just wondered, when you talk to the local units, are you saying, go talk to people in Clinton County?
Yeah, definitely using them as a model. They've been very willing to showcase that. We
going and what other states, where they're falling, and if there's something we need to be more helpful. I mean, I like the sheet about errors and best practices.
Of course, yeah. So we are fortunate to join calls with a lot of our counterparts across the country who are doing this work. And I will say that Indiana is really leading whenever it comes to spending these dollars. I think both at the community level, but then also incredibly at the state level, the impact that we've been able to make just in the first couple of years. We were one of the first states to start getting dollars out. And part of that is because we have really tried to maximize efficiency and use an already established commission to make some decisions. And then also, we've got processes in place to spend funds already based on federal funds that we receive. And so we're attuned to that process. I think whenever it comes to the local communities, you'll look at the list, which is available on our website, and it's a large Excel sheet, which is why it's not included in this. And you can see line by line which communities have spent their funds. And they're more likely communities that you've actually heard of, who are larger communities. I think of Bloomington being one of those communities who has spent funds, as well as counties. And so I think we want to give reassurance, like I said, that this is not necessarily a bad number. It speaks to the fact that we needed to put out some sort of guidance in addition to Exhibit E, because it's an 11-page document with a list of lots of strategies that may or may not even apply to Indiana. And so to be able to provide something that supplements that, as well as the list of items that just are not included explicitly in as an allowable use in Exhibit E, we think that we'll hopefully be able to drive that number down in 2025 and hopefully see a larger number of funds expended and for the right use in 2025.
Any further questions?
Thank you. During our preparation of the budget request for DOC, it came up multiple times of substance interdiction in the facilities, and Commissioner Weigel has continued to say minimizing substance use inside the prisons is always going to be an easier battle if we have interdiction in conjunction with treatment resources. Is there ever going to be an opportunity to look at or have a discussion about these items that are not allowable under Exhibit E and look at if there is room to make an adjustment to that?
Yeah, so the lawyers in the room may be more adept to speak to this, but Exhibit E does come from the National Settlement Administrators, and so that is specifically written into a lot of the settlement agreements. And so I think a lot of the focus is on abatement, and whether or not interdiction falls into abatement, I think is a discussion that still needs to be had. But I'll rely on the lawyers in the room if there is anything to add to that.
The only thing that I would add to that is when we're talking about abatement, we're talking about the restricted funds. There can be pleas made to the legislature from a funding standpoint to use the unrestricted funds for interdiction or other efforts of that. But again, that is a budget consideration for the state as a whole. But those limitations